So we have just a couple of minutes if we steal them. Is there any questions from the audience for the speakers? And would any of the speakers just come up for a moment in case we have a question for you? Yes, Raul.
Yeah, I have a question for Phil. Phil, you showed us in your really fabulous study that at 5 years, hemoglobin A1C with sleeve or gastric bypass seem to be equally effective. However, when it comes to the use of medication, there is such a big discrepancy, and it's significantly higher use of medications in the sleeve population than when the bypass. Any explanation for that discrepancy, hemoglobin A1C at the same level, but use of medication much higher?
Is this on? Okay, great. Yeah, thanks, Raul. Yeah, that's a really important clinical question that surgeons have to wrestle with every day, is which procedure to use for diabetic patients, which one's more effective. And our study showed that at 5 years, the A1C was fairly close. Yet, when you look at the medication profile, the patients who had the sleeve were on more medications, more insulin, more oral agents than those with the gastric bypass, suggesting that there is better glycemic improvement with the gastric bypass when you account for not just the A1C, but also the medication usage. So what accounts for those differences? Well, there was a little better weight loss in the sleeve patients, and we know that that by itself improves insulin resistance. And then there's all these other mechanistic factors that are more difficult to measure, the incretin effect and those types of things. We did measure the incretin effect in a sub-study at 2 years, comparing the bypass and the sleeve. And we looked at relative levels of the incretins, particularly GLP-1, and we did see a more robust response in the bypass and the sleeve. We saw a response in both of them. But that's just one of, perhaps many mechanisms that might explain the differences, I think we need to look at, longer-term follow-up on these, perhaps different subgroups of patients before we can, clearly state, which operation, to use. Clearly risk is important, operative risk. So it may be that higher risk patients, you accept maybe a compromise in the glycemic benefit and weight loss benefit for a lower risk with the sleeve than the bypass. So we're actually working on an algorithm right now to help surgeons begin to sort of address that, and we hope to publish that fairly soon. Thanks.
Identify yourself and your question.
I'm Dominic Asman. Dominic Asman, a third-year resident at Kern Medical in Bakersfield. Thank you all for your interesting presentations. My question is for Dr. Rosenthal. Do you see the idea of modules and milestones being applied to all the training programs under the Fellowship Council? And if so, would this mean setting a minimum and maximum time allotted for the trainees to reach those milestones instead of a set one-year program?
For some reason, I cannot hear the question from here so well. Did you guys?
We want to know if the milestones were going to be across the board at all programs.
Oh, yeah. The milestones are going to be across all programs. The American Board of Surgery is now debating and changing the current training model of doing residency 5 years and then do another year of fellowship to do a residency for 4 years. And in the last 2 years, you will already transition to a chief year where we are just a fellow. In fact, we've been given the freedom to already in the 5th year of training for a resident to make them function as a fellow in the specialty that he or she is going to choose. So I think the milestones are very important. But what I try to relate to you today is that it's not anymore the milestone, but it's the module within the milestone that matters now. And each module has different milestone by itself that you need to achieve. And now we are adding to the module and the milestone the entrustable professional activity. So it is a little bit complex for everyone to understand, including ourselves. But it's a price we're paying for this rapid evolution. And just to make this answer a very short one, we are trying to make training more related to your qualifications, your quality, and not just time. There are residents that can achieve excellence in what they do in 3 years. There are others that will never achieve that excellence, or it's going to take them 3 times as much time. So we shouldn't penalize everyone for those ones who take longer. And we're trying to adjust our training system to that. I don't know if I answer your question.
Definitely, and that would include then changing the set time so that some people may train less time and some
Correct.
longer.
I think that CMS in the future is going to tell us if you can train a resident in 4 years, why should I pay for 5? But we need to adjust our systems to be able to deliver that.
Thank you.
Our last question for the session, it'll be Dr. Shower.
Yeah, great. So this is a question
We're
for David.
stacking the audience, as you can tell.
For David, regarding the MBSA QUIP focus on short-term outcomes, everything that has been addressed so far are sort of perioperative complications, but not so much as long-term, outcomes in terms of benefits of the procedure, weight loss, glycemic control, blood pressure, those types of things, which is much more difficult data to get and maintain. So can you speak to that goal of longer-term outcomes?
Well, we do differ from the NISQUIP in that we're not just limited to 90-day outcomes. We do track the data on comorbidity resolutions, long-term weight loss. The problems that we have as the MBSA QUIP, same problem we all have as surgeons, and that's in our long-term follow-up and getting the patients to come back. And so that while we will have the data, being able to compare it or benchmark it between other programs, I think will be difficult. But I think over time, just the huge volume of long-term follow-up that we will have, I think will provide at least some evidence of what the long-term outcomes of bariatric surgery will be.
Well, I'd like to wrap up this session. We went over time, but I did give it a chance to have some dialogue. I appreciate the speakers. Anyone who has any other questions, please tackle our speakers on their way out. Thank you for participating. Have a good evening.